Today I will discuss Mycobacterium leprae, which produces a disease known as leprosy or Hansen's disease. Leprosy is an ancient disease associated with social stigma. Historical records and literature show that people afflicted with leprosy have often been ostracized by their communities and families. By the end of this session, you should be able to describe mode of transmission, pathogenesis, classification, differences between two main types of leprosy, and laboratory diagnosis of Mycobacterium leprae. I will discuss clinical features in these differences between two main types of leprosy. Humans are the natural host for this bacteria, and optimal temperature for its growth is 30 degrees centigrade, which is lower than the body temperature. Mycobacterium leprae cannot be cultured on artificial media or in cell culture. However, it can be grown in foot pad of mice or armadillo. This armadillo has low body temperature and is highly susceptible to lepra bacilli. It grows very slowly. The doubling time is around 14 days, which makes it slowest growing human bacterial pathogen. Mode of transmission of Mycobacterium leprae. Prolonged contact with leprosy patients is necessary. Patients discharge Mycobacterium leprae in large numbers through nasal secretions and from skin lesions. Nasal secretion contact is more responsible for this infection, which is through inhalation of droplets, than through skin lesions. Pathogenesis of Mycobacterium leprae. Bacilli are discharged from nose of infected person and they are inhaled by susceptible person. Once they are taken up by alveolar macrophages, they disseminate through hematogenous route and reach nerves and skin. Target cell for leprosy bacillus is Schwann cell. Schwann cells are responsible for formation of myelin sheath. So once these cells are damaged, this can lead to nerve damage and there can be anesthesia and muscle paralysis. The organism replicates intracellularly not only within Schwann cells but also the skin histiocytes and endothelial cells. Ridley-Joplin classification. But just before that, I will briefly discuss WHO classification, in which there are two main types of leprosy. The first one is paucibacillary leprosy, and in this form of leprosy, few or very few Mycobacterium leprae bacilli are present in skin lesions. The second one is multibacillary leprosy, and in this form of leprosy, many or multiple bacilli are present in lesions. Now let's talk about this Ridley-Joplin classification. Progression of disease will depend on patient's immune response to Mycobacterium leprae. So in this case, you can see once there is an exposure and the cell-mediated immunity is very high, so this infection can resolve itself spontaneously. If the cell-mediated immunity is fairly high, there can be tuberculoid form of leprosy. If it is poor cell-mediated immunity, there is lepromatous form of leprosy. If the cell-mediated immunity is in between tuberculoid and lepromatous leprosy, we have got another category which is borderline disease. So you can see the first one is borderline tuberculoid leprosy, which has features more of tuberculoid form. Then is borderline lepromatous leprosy, which has features more of lepromatous leprosy. And then in the center is borderline. It has features of both tuberculoid and lepromatous leprosy. For us, this tuberculoid leprosy and lepromatous leprosy is important, and we will discuss differences between these two main forms of leprosy on the basis of clinical features. In case of tuberculoid leprosy, the lesions are few in number. They can be macular, dry, or plaque-like hypopigmented lesions, and they can be anesthesia patch, and the nerve involvement is early and asymmetrical with minimum disfigurement, as the immune response is functioning well. In case of lepromatous leprosy, you will find many lesions. They are nodular, shiny, and leonine facies, which means line-like. There is little or no loss of sensation, and there is late and symmetrical involvement of nerve. As the cell-mediated immune response is poor, so there can be maximum disfigurement like saddle nose, pendulous earlobes, and claw-shaped hands. We have already discussed few of the differences between tuberculoid and lepromatous leprosy in previous slide. Let's start from here. The cell-mediated immune response, which is good in case of tuberculoid leprosy, so you will find few acid-fast bacilli with less likelihood of transmission of this disease, and as the body is able to mount an immune response, so the lepromin skin test would be positive. You can also find granulomas, and I hope you remember these granulomas from Mycobacterium tuberculosis lecture. In case of lepromatous leprosy, the cell-mediated immune response is poor. You will find many acid-fast bacilli in Zn staining, and there is high likelihood of transmission of this disease. As the human body is unable to mount an immune response, so the lepromin skin test would be negative. And instead of granulomas, you can find lipid-laden macrophages, which are called as foam cells. Laboratory diagnosis of Mycobacterium leprae. Skin slit smear can be taken from ear lobule, nasal mucosa, or any lesion site. Skin is cleaned with spirit swab and pinched to minimize bleeding. Scalpel blade is turned at right angle transversely to scrape sides and bottom of cut to get tissue pulp. Skin biopsy can be taken from edges of active patches. So once smear is ready on a slide, the next step is to perform Zn staining. In stained skin smears, they are seen lying singly or in clumps, or you can say compact masses, which are known as globi. And this would be seen in case of lepromatous form of leprosy. Antibody can be detected against phenolic glycolipid antigen, which is part of cell wall of Mycobacterium leprae, by these two serological methods. We have discussed about culture before. You can go for PCR, and then there is late or Mitsuda's reaction. So the antigen used is Mitsuda's antigen or bacillary lepromin, and it appears 3 to 4 weeks after intradermal injection in the form of a nodule, which may ulcerate or subside in few weeks. In terms of mechanism of action and appearance, the reaction is similar to positive tuberculin skin test of patient who is suffering from probably tuberculosis, and this reaction is a manifestation of cell-mediated immunity induced by lepromin. A quick recap. of what we have discussed regarding clinical features of two main forms of leprosy. So in case of Lepromatous leprosy, leonine facies, line-like. In case of tuberculite leprosy, macular or plaque-like skin lesions. And the disfiguring appearance of this disease can result from several factors. For example, there can be skin anesthesia, which can result in burns and other traumas, which often become infected. Similarly, there can be resorption of bone, which can lead to loss of features such as nose and fingertips. There can be infiltration of skin and nerves, which can lead to thickening and folding of skin. Patients with forms of the disease intermediate between tuberculoid and lepromatous can progress to either extreme. So these are major signs of leprosy. We have already discussed these cardinal signs of leprosy. The history of residence in an endemic area is also an important point which you should consider. Thank you.